I've increasingly come to believe that everything about company building, every role you play as a CEO and a founder is about selling. It's about negotiation, and it's about persuasion.
I'm Stan Christensen, and this is All Things Negotiation. Today, my guest is Toyin Ajayi. Toyin is a physician who is trained at Stanford, Cambridge, and Boston University. She's one of the great entrepreneurs who saw a problem and did something about it through a for-profit company. She created Cityblock Health to help administer healthcare to Medicaid population, those that are underserved traditionally in the system. We talk about her journey in starting Cityblock Health, what we can do overall in our country and the healthcare system, the myriad negotiations that happen between providers, clinicians, regulators. I think you'll really enjoy the conversation. Welcome to the podcast, Toyin.
Thank you so much for having me.
I've been so excited for this conversation. You, in our conversations, are really one of the most insightful people I've talked to about healthcare. And healthcare is so complex. And so you are a doctor, you're practicing in the Boston area, servicing a difficult population, and saw a real need. Before we get into Cityblock Health and all of your success there, I'd love to just understand what you saw as a gap in the offerings for Medicaid patients. Help us understand that population a little bit leading up to you founding Cityblock Health.
Awesome. Well, thanks for that tee up. So I started my career in medicine. I did my residency training at Boston Medical Center in Boston, as you said, which is by most accounts, one of the best places in the United States, frankly, on the planet to get healthcare. Unbelievable tertiary institutions, incredible researchers, the heart of the biotech industry. There's so much going for that sort of geography in terms of access to excellent healthcare. And I trained as a family medicine doctor, taking care of newborns, delivering babies, all the way through to sort of end-of-life care for seniors. And a big chunk of my time was spent in the hospital, taking care of people with acute medical, physical, often psychiatric needs. And what I found pretty early on was that what we were doing wasn't working. We served a primarily Medicaid population. So these are folks who qualify for state and federal government-sponsored insurance by virtue of being low income, as well as people who are dually eligible for Medicare and Medicaid, which means that they're eligible for additional government-sponsored insurance by basis of being either a frail senior, living in poverty, or being a young person with a disability. And what we were doing was well-intended, for sure, but we were providing sort of snapshots of healthcare, waiting for people to come to us, and therefore almost definitionally finding them when they were at their worst, when things had accelerated and exacerbated such that they had no other options. We were providing pretty limited services, getting people patched up so that they're well enough to go back, and then sending them back to the same environment and circumstances that caused all the problems in the first place. And it started to feel like a revolving door. We would discharge someone who'd come in with an overdose of their opioids and had a cellulitis, an infection in their leg. We would treat them with antibiotics. We would initially stabilize them from their withdrawal. Then we would discharge them again, and the same cycle would repeat itself. And even in the community, on the outpatient clinic side, most doctors in the community and health centers have to see as many patients as they can every day. They're often booked, every 10 minutes. Very rarely do they have time to really take the fullest history that they could. Very rarely are they able to visit someone's home to understand and discover why they're not taking their insulin. Oh, it's because they don't have a refrigerator. Or, this medicine, it says take it with food, but they actually only eat once a day. All of this stuff that's really, really important to people's well-being wasn't being taken into account. And we were waiting for people to come to us as opposed to going to them and meeting them where they were. And that for me really inspired a real passion for getting further upstream and trying to understand the real drivers of health, specifically for this population, trying to figure out how we could redesign healthcare delivery to meet people where they are instead of waiting for them to come to us, and figure out how we can incorporate this understanding of the broader milieu and the context in which people live, their social circumstances, their access to resources, their relationships. All of that plays into their health. How do we actually participate in that conversation with our patients as opposed to ignoring it and focusing only on the organ system that happens to be diseased that day? And that for me has been the sort of underpinning of my personal passion in my career as both a practicing physician and then as I've evolved into more leadership roles like the role at Cityblock.
Amazing. But let me dive into a couple of things there. There's so much. We could spend the whole session just on, negotiations within the healthcare industry, whether it was providers, insurance, people, patients. But you were motivated to start a company, Cityblock Health, and it's been wildly successful. But what problems are you specifically trying to address through Cityblock Health? There's a lot there.
Yeah, absolutely. At its core, we have a system that is failing every part of the system. So patients do not get better and do not get the type of care they need and deserve when they are shuttled in and out of clinics, on a 10-minute basis, when their full clinical needs are not taken into account, their social needs aren't taken into account, and when we wait until their needs are so bad that they're in the hospital, they're in the emergency room in order to spend all these resources to care for them. Patients tell us, and we see this actually in the data, coming from so many different angles. We actually now see it, I think, in the political conversation about healthcare. People don't feel heard, and they don't have high levels of trust in healthcare. They don't feel like we're serving their needs. The consumer is saying, this isn't working for me. And that is particularly true the sicker you are and the lower income you are, the lower your satisfaction and trust with the healthcare system is. So that's one constituent that it's not working for. And entrepreneurship really is about solving problems, market failures, and seeing a gap, right? So that's the problem on one side. We have another stakeholder that's also not having their needs met. Doctors, like I was, when I started my practicing many years ago. Doctors are burning out. Nurses are burning out of healthcare. We increasingly start to understand that the reasons for their dissatisfaction with the quality of their work have less to do with the number of hours they're working. Objectively, physicians today work sort of fewer hours, even trainees now, than they did 20 years ago or 30 years ago and 40 years ago. It's not that the work is bad. It's that the nature of what you are doing and the sense of satisfaction you're able to gain from that work has eroded. And so physicians and researchers have talked about moral injury for physicians and for other healthcare providers, which is that feeling that you're working really hard at something, but it's actually not causing the outcome that you want. In fact, it may be worsening things. That feels bad to people and it makes them dissatisfied. You layer on the ways in which technology have historically sort of abstracted us even further from the human interpersonal relationship. And then the third constituent is the payer. And in this case, it's all of us. Again, it's the taxpayer. Healthcare costs are going up. Healthcare in the United States, I remember a decade ago, we were wringing our hands. We're going to spend 20% of our GDP on healthcare. We've now exceeded that. We're continuing to see costs go up. And yet, relative to every other developed country, we have worse health outcomes on a per capita basis. When you adjust that for how much we spend, objectively speaking, we are getting the worst value for our dollar of any other developed country. Right? So the thing isn't working. What a great opportunity to disrupt, right? And what an opportunity to innovate. And our innovation and our insight has basically been that you can actually achieve all of those goals, reduced cost, improved outcomes, and improved satisfaction amongst all the stakeholders in the healthcare system by reorienting how we deliver care, by going to people's homes, by meeting them in the community, by spending the time to understand holistically what matters to them, and by solving for their needs in a proactive way before they're calling 911 and ending up in the emergency room with an asthma attack because they ran out of their inhalers 3 weeks ago. Let's get upstream. And we built a business to do that. And that requires us to hire doctors and nurses and social workers and therapists, to build technology that orients the care team in a totally different way, to get outside of the clinic and the bricks and mortar and actually go meet people in their homes and the communities, and to ensure that we are contracting in relationships, financial relationships, such that when we see a reduction in medical spend for the population because they are healthier, we get to keep some of that as our margin, and we get to pass the rest of it off to our customer, to the payer, the health insurer in this instance, and ultimately the taxpayer.
Let's dive into the last piece of what you said. Your customer is actually the payer. So you're going to a large insurance company and saying, if I understand correctly, we'll take your Medicaid patients off your rolls. We will administer the actual clinical health care and do it cheaper than you can with better outcomes. Is that correct?
Yeah, I mean, they retain the insurance. They're still the insurer. They still have accountability. But what we're saying is we're going to help you achieve the goals that we know you want and that your patients want, which is higher quality, better engagement, and managed medical spend such that people are utilizing services appropriate to what they need. We're going to support all of that with our platform and our caregivers, our clinicians, and non-clinical teams to ensure that you achieve those outcomes. That's right.
Amazing. Well, let's dive into the company now and how you created it, because it almost sounds too good to be true. Every entrepreneur I've ever talked to has said, yeah, it looks easy, but there was a lot of friction along the way. It wasn't always smooth sailing. So I'm guessing you fit in that category. Let's talk about how you convinced other doctors, employees to come on board with your vision. As you think about negotiation and how you persuaded people to come on board, what were the key things and what would you advise a younger entrepreneur about negotiation skills and persuading people to join your vision?
Yeah, I mean, one of the reasons why I was so intrigued by this podcast is because I've increasingly come to believe that everything about company building, every role you play as a CEO and a founder is about selling. It's about negotiation and it's about persuasion. And so at every step, I think, first acknowledging that. I did not know that when I started, right? And so you start with this big vision and this idea and you're like, I see this thing, everybody should come join me. And that, that only works so much. And over time, you have to get really strategic at understanding who your audience is and how you actually persuade them. You need to understand the motivations and the desires of your intended audience, right? And that's different for each stakeholder. So when you're growing your team, what you are doing is you are convincing a person who's like worked really hard, built a career, has landed this like wonderful stable job at this company that has a 401k and like does all these great things that companies do, like will probably exist in 2 years, like there's a lot of certainty associated with that. They've got bills to pay. And you're convincing them to sort of give up all of that and take a risk on something that frankly may not be around in a year or two for less money and the promise of this great outcome on the other side. That's non-trivial. And there's actually probably a little bit of a mismatch between the people who might immediately hear that prop and jump in and the people who you actually want to be at your company, right? Like most people would think about that and think, wait, is that a smart decision? And you want those reasoning people to really get through it. And what I found is that within your sort of employee base, different people are motivated by different things. And you need to understand that. When we were building the company, we were very focused, of course, on getting the right clinicians to join us. And for a clinician, again, a lot of them have student debt. A lot of them are really thinking about stability for the long term, but they're also struggling with this thing I described earlier, the moral injury, that burnout, that exhaustion, that sort of the dissonance between the values and the passion and the mission that drove them to medicine and the drudgery of their daily work. And that was the insight. It was like, oh, people are going to come do this with us because of the promise that at the end of the day, they can look at their desk, they can look at their work environment and say, I did something really good today that changed a person's life. And that was the value prop and continues to be the value prop for clinicians joining Cityblock. For our operators, there was a little bit more of a risk-on kind of environment. Entrepreneurship from the outside in looks really sexy, right? It looks fun. You're not in a big institution. There's not an HR department telling you what to do and a this and a policy and a that and whatever. Like people have seen, the sort of allure of tech-driven innovation in the United States is such that people have seen others make massive careers, have great financial wealth and build like real stories for themselves by striking out and doing something different. And that excitement about building something that never existed before, about getting to write the rules, getting to be part of a fast-moving rocket ship is really compelling, particularly for younger people who are interested in learning how to operate. Because where else are you going to get the opportunity to bat that far above your pay grade, right? Like to one day get tapped to do this big project that's going to turn into being the thing that unlocks your next chapter in your career and propels you to an IPO one day. And that story, I think, was really compelling for the folks we recruited to join our team as operators. For technologists, it's a slightly different story, right? I think a lot of folks we brought to our team early on had built their careers in Silicon Valley, many of them doing consumer product and consumer tech. And many of them built really amazing businesses and products, but none of them got the feeling of, helping to change like a really hard problem, to address a really hard problem and to really make a difference for people. And when you're sitting at the dinner table or at cocktails with your other tech friends and they're, building a new consumer app or they're doing something in gaming and you get to say, no, the technology I'm building helps like low-income folks all over the country better access healthcare. and reduce mortality and morbidity, it kind of hits different, right? And that's an opportunity for folks who want to use their skills as much as possible to have an impact in the world, but they don't happen to be a doctor or a nurse. They happen to be a software engineer. This is a place where you can do that, right? And that's what we sort of learned was a real selling point for folks and helping them decide to make the leap and take a chance on us.
Well, I think you're a natural salesperson. And if I were a potential employee hearing that pitch, I would say, I want to jump on board. I'm reminded of a story I once heard. Steve Jobs was trying to persuade John Sculley to come be the CEO of Apple. And John Sculley had a big corporate position at Pepsi and was resisting. And Steve Jobs said to him, he said, John, do you want to spend the rest of your life selling sugar water, or do you want to help me come change the world? And that one line, convinced him. Yeah. And what I say to my students, and it's very consistent with what you're saying, is the biggest risk in your employment is unhappiness at your job. And if you go to a big, slow-moving company where you're a cog in a wheel, you're probably not going to be that happy. I want to talk about one more thing in terms of your team. I think it's notable that your senior team is all women, unless I'm mistaken.
A lot of women. They're not all women, but a lot of women.
It's a lot of women, and that's amazing. Are there things that are unique about women in senior roles that you've found that are different than men in senior roles, and how you either structure the organization so that it will support unique things about being female? Just talk about diversity at the top and what you've learned there.
Yeah, I mean, I love our team. We are so lucky. We have an incredibly talented team that I think reflects the distribution of talent across our country, frankly, that it's not just concentrated in specific gender or race or educational background or anything like that. And I think actually the pandemic opened a door, I think, for many companies in terms of understanding the extent to which flexibility around work can empower and enable particularly parents to fully participate. And I don't think this is just a gender thing, actually. I think, the dads on our team really value being able to coach their kids' little league game and go see the play that their middle schoolers putting on and things like that. And so what we have done, and I'm really proud of that, is have said, we focus on outcomes and execution and performance. We look for talent wherever it comes, in whatever package it comes in. And my job is to create an environment in which people can unlock that talent and capability and contribute to the max of their ability. And that means that flexibility in terms of, I don't expect you to, show up and be at the desk with a tie on at 8:00 every morning and not leave until the boss leaves at 6 p.m. I expect you to get the work done. And to do that in whatever way you need to have it be integrated into your personal life so that you can thrive and be your best self at work. I do think that there's representation matters. And I think people take cues in terms of the culture of the company on the basis of what the team looks like and the senior team looks like, right? And so if folks see a senior team of men, all men, they make some assumptions about what that culture would be and how receptive it would be to them if they don't represent that demographic. And so I think there's a lot of value for us in having a team that is very diverse and very representative. It means that we're basically, what we're signaling is like, doors wide open. Any kind of talent should come and feel like if you can deliver, you have a role to play here. And that's really allowed us to tap into some really excellent people.
One of the things that you and I have talked about in the past is this dynamic where, and again, these are generalizations, but I think important to discuss, women often really want to be liked, and they see that sometimes as a conflict with being hard charging. A, do you see that? B, how do you address it? Is that a real thing or not?
It's a real thing. There's data about this. And it's not just a perception. I think the world perceives hard charging women differently than it perceives hard charging men. Like, we've seen the data on that also. And there can be negative consequences to being hard charging if it doesn't come in a package that people expect it to come from. And again, I think this is where having a really diverse team is just sort of almost definitionally helpful. It allows us to say that people come in all different shapes and packages. Hard charging people come in all different forms and packages, and less hard charging people come in all different forms and packages. And so there's less of a sort of stereotyping because we have such heterogeneity. I think I also personally, as a leader, I value candor and I value directness and I value ambition and I value aggression, actually. What we are solving for is really hard. People need to have like a fire in their belly to get it done. I value people who hold themselves and others to a high bar. And so we've created a culture in which it is normalized that those traits are reflected by our leaders who are successful, no matter who you are, because that is the expectation. It comes along with, I think, also valuing the importance of human connection, of kindness, of empathy, of thoughtfulness, of consideration, and certainly of emotional regulation. I expect people to, to be really intentional about how they show up. But all of those things can coexist, and they can coexist in any kind of human. Like that is the sort of recipe for excellent leadership. And we expect that and really try to cultivate that in folks.
Well, congratulations on your team. How many employees are you up to now? I haven't touched base with you.
Yeah, we're about 1,000 employees now.
1,000 employees. That's a lot of people to keep track of.
Yeah.
Let's shift gears and talk about one of the hardest things for young companies, which is enterprise sales. You happen to choose insurance companies as really one of the primary groups that you sell to. I'm on the board of a company that does enterprise sales into insurance, so I know a little bit about that. And they don't make decisions quickly. They're not particularly innovative as a rule, in my experience. So how did you make that first enterprise sale? So think about the negotiation and persuasion involved in selling an insurance company on your very novel approach to administering healthcare for Medicaid patients.
Yeah, we were very fortunate in our first customer, and I think folks will acknowledge this. Often your first sale comes on the back of a prior relationship, either an investor, a board member, a warm introduction. It's a lot to ask of a company to take a bet on an incumbent, a brand new entity. At that point, they have no customers you can reference. It's a PowerPoint and a set of ideas. And we were really fortunate in our first customer that we had a relationship with a really forward-thinking health plan leader who understood the problem really well, understood the opportunity in her population, in her business, and was willing to take a risk with us. And the sort of the value proposition for her, for that executive, was a couplefold. One, it was the opportunity to be a leader and to be an innovator and to be ahead of her competitors in that market by partnering in a way that was really different. Second was the ability to influence our business and the way that we shape our business such that it would actually deliver outcomes. And I think you can do that explicitly and implicitly with early customers, just to say, look, you get to, yes, you have to, the downside is you're working with a brand new company that doesn't know what it's doing, right? Like it's legit, we'll own it. The upshot is you can help us and you get to shape how we focus and what we deliver with your own needs in mind, because you, for a long time, will be an anchor and critical customer. I think the other opportunity, health plans are insurers. They underwrite insurance risk for a pool of folks. Their job is to contract networks, is to pay providers. And one of the things we found is that is typically as we sell, we typically are able to cultivate a champion within the organization who's either a business leader or a clinical leader who just gets it. And they get it because they can see the limitations of what they are able to do within the constraints of their business model and their expectations around that business model. And they can see the opportunity to do more and to do differently for these folks whom they serve. And that, I think, is actually really powerful. And being able to really sort of say to them, it's not your fault that you can't go into the home and provide care to these folks. That's just not what your business is set up to do. But you and I both know that's what needs to happen for this subset of the population that has the most extreme needs in your population of folks. They need more than most of the doctors that you have contracted with can do, and they need more than the health plan can do. Let's help you. And they get it. And that gives an opportunity for us to then sort of build the partnership with that anchored champion within the organization.
Interesting. Let's dive into, related to that, are what you call value-based arrangements. I think this ties into preventative care. It ties into cost sharing. Again, I hear cost sharing. Let's assume I'm a provider, an executive, and I have my clinicians saying, "Hey, we ought to do this. Preventative care is great, but cost sharing? I'm not sure I want to do that with a startup. Do you ever have any hurdles when you propose that?
Well, so the way that we partner is we partner with the health plan, and yes, we enter into a relationship where we have skin in the game financially in ensuring that we deliver outcomes for the population. So we don't get to bill for a preventive care visit that results in a prescription that the patient never picks up. Then if they end up in the emergency room, that is the typical way that healthcare gets paid for, is that clinicians and health systems get paid on the interactions that they deliver, as opposed to on the outcomes that they actually are able to achieve for a population. So that is a really unique nuance of the way that we partner. We're not the only company that does that, but it's a growing movement to sort of enter into value-based or outcomes-based relationships that allow us to really tie those incentives together. And the trade-off for the health insurer, for the customer, is that they give up some of the financial upside in the event that people do, in fact, get healthier and their medical spend goes down, because they have to share it with us. But again, they have to believe they're getting value from us in order to want to sell, to want to enter into that relationship. And what we've been able to do is prove that we deliver value such that the value proposition makes sense to them. It is worth it to give up some of the upside in order to ensure that they actually can achieve that outcome, as opposed to holding on to all of that risk and also living with a likelihood that they're going to find themselves with escalating medical costs, worsening engagement and worsening retention in the population as people age and get sicker, which is the counterfactual that is more likely to occur. And so that's the business, and that's the sort of the way that we're able to convince folks to partner with us and to give up some of the economics such that we can also grow a business supporting them as they grow their business.
I get that over the long term, but one of the primary hurdles to administering effective healthcare seems to be alignment of incentives, and I don't think everybody's aligned. I may be oversimplifying, but if I'm a hospital system and I'm paid for procedures, for example, how much do I care about preventative care? I get that the insurance companies, your client, cares about preventative care, but am I right that the incentives aren't necessarily aligned in healthcare, or am I missing something?
You're correct. You're absolutely correct. They're not aligned all the way through the healthcare system at all. And there's so many reasons for that. We could do a whole other podcast about the ways in which we've created a regulatory system and a marketplace that, first of all, makes it really hard to understand what value is. So it sort of obfuscates outcomes and distributes accountability for those outcomes so diffusely that it's really hard to create alignment around incentives over the long term. Think about this as an example. Most people in the United States get their insurance through their employer. That is pretty unique to America amongst developed countries. And what that means is that your insurance is likely to change probably more than 3 times over a decade. You switch jobs, you get a new insurer. Your company chooses a new health plan, you get a new insurer. Your partner loses their job and goes off their insurance and comes on your insurance. There's all this churn. And so the insurer, the payer, if they meet you today, has very little incentive to invest in ensuring that you do not have a heart attack or develop diabetes 5 or 10 years from now. Because the likelihood is very high that if they make an investment now, the returns will be realized by somebody else financially. Even just as a basic example, right? The example you put forth, which is that, we have a fee-for-service healthcare system, which means that health systems, hospitals, specialty providers make money on procedures and on providing care. And we value acute care and more complex care for more severe illnesses higher than we do for lower acuity. So we pay way more money for hospitalization to stabilize somebody who had an acute heart attack because their diabetes was uncontrolled and their blood pressure was through the roof than we would pay their primary care doctor to prescribe a statin and a blood pressure medicine. And so we are actually not incentivizing preventive care, and we're not creating alignment across the system around the notion that actually we want people to get healthier because we want them to get care in different ways in different places to prevent the exacerbation of their illness. So you are entirely correct. And it's a pretty macro problem that needs a lot of really nuanced solutions. We can take a sliver of it by creating these sort of pockets of places in which we create alignment. So if you have alignment between two parts of the system, between the insurer and in this case, Cityblock as the provider, we can then coordinate around everyone else. But fundamentally, we have a lot of opportunities, I think, to further and deepen that alignment in order to achieve better outcomes as a society.
I'm hesitant to do this, but let me expand the complexity to regulators. You're big enough where I think you probably play a role with regulators. You've mentioned a couple of times things that are unique to our country. We've got some of the worst outcomes, some of the highest costs. I think we're probably the only country that I know of that doesn't negotiate drug prices. I think we've got, CMS sets payment models. So how do you negotiate with regulators? Do you spend time doing that in your role, or what would your advice be to those that do?
Yeah, I think the regulators are actually a really important player in all of this, and have so much power and an opportunity to change things. I think CMS really tries to play this role of convener and aligner and
just define CMS for folks that may not be familiar.
It's the Center for Medicare Services. So that is the federal government entity that sits under the Department of Health and Human Services that's accountable for administering $1.5 trillion, essentially, of taxpayer revenue that goes into paying for healthcare via Medicare, which is insurance for people over the age of 65 and people younger than 65 with disabilities, and Medicaid, in which the federal government matches funds put forward by states to support lower income people and pregnant moms and kids. And so that's a huge chunk of funding, payments for healthcare services provided that the government administers. It does so through various vehicles and has quite broad regulatory latitude to determine what gets paid for, what we prioritize, what innovations and models of innovation are funded and really thought out, what expectations and requirements are of health systems that receive government funds, what we cover in terms of preventive care and care for seniors. It's really quite a powerful opportunity. But like so many regulatory bodies, it's complex because our rules, like any other country and in any other bureaucracy, did not all get written at once. They layer on top of each other. And you create a regulatory framework, you think it's going to do X, and maybe it does X plus Y. And Y we don't like. Y is an unintended consequence. So we put in another rule to try to mitigate the downside. But the market likes Y because it makes money. And on we go, layering on layers and layers and layers of regulation, many of which require Congress's approval, right? And so it is non-trivial. I think it's really easy to sit on the outside and say, oh, if only our regulators did X or Y, it would be so much easier. And the truth is, these are very complex systems that hold together sometimes quite delicately and in very intertwined ways, and that have been built over decades. There are opportunities. So the Center for Medicaid Innovation is a small agency that is focused specifically on innovation. It's funded to put out programs, pilots, bundles, a whole host of different ways to sort of push the notion that we should create better alignment and that we can tackle specific conditions, disease states, or parts of the healthcare ecosystem with a mandate to disrupt and to innovate. And I think that to the extent that different administrations behave differently, but those that have been most open to input and feedback, I think find that they can actually make real change and move the needle forward. But it takes a lot of alignment of political will and resourcing and time to do so.
I hear that as a layperson, and I say, gosh, we're not a single-payer system, but we may have more administrative complexity than countries that are single-payer systems. So we've got kind of the worst of both. Is that oversimplification?
We have a lot of administrative complexity, that's for sure. I mean, I spent a lot of time in England earlier in my career, and they have a single payer system. They are mired in it, in complexity, in cost, in frankly poor outcomes at this point as a result of a whole host of decisions that were made over time in the way that they actually administer the funds. And so it is not as simple as saying if we had a single payer system, everything would be fine. We still have to figure out how to administer those dollars. And we have to decide what we pay for and what we incentivize. And we have to build alignment across the patient, the community member, the state, the provider, the payer, all along the value chain. And that work has to happen no matter who's paying the bill ultimately. That's actually the hard work. And there's not a lot of places that have successfully landed it without many, many, many decades of iteration.
Last kind of wonky administrative question. Why don't we negotiate drug prices? And how would you do that, assuming you think it'd be a good thing to do?
It's interesting. We are starting to do that. So the last administration, for the first time, had a list of drugs that they chose to negotiate prices around and prioritize. That is being continued in this administration. We're seeing increasing conversations about how to make the drug marketplace, and specifically the prices that are charged in the United States to American consumers, more on par with what is being done globally. I think the simple answer, I don't think I'm as far as I can tell, is lobbying, and the sort of the system by which we make decisions about what we prioritize in terms of regulations. And I think that we've gotten to a place where the burden has become untenable for consumers and for payers. And now there's actual political appetite and will to take this on.
Here's hoping. Let's kind of go back to your constituents. These tend to be poor people who might not be accessing the healthcare system in the way that the providers would like. I'm guessing they're not very trusting of clinicians sometimes. How do you negotiate trust? This is a thing that comes up over and over again, which is how do you get that? You're this sophisticated person that went to Stanford and then got educated at Cambridge and Boston, and you don't really feel like a lot of the people on Medicaid to me. I'm guessing that it hasn't been rosy in terms of getting them to trust you. Am I correct in that assumption?
It's interesting. I think a lot about trust and spend a lot of time with our teams building systems to engender trust. And again, you and your teams understand this as well as anyone else does. Trust is actually, it's not that complex. Who do you trust? You trust somebody who you believe. What does it actually even mean? It means this is a person or an institution that you believe has your best interests at heart, who takes the time to get to know you and who makes you feel like you're important and valued. Anyone can engender trust, I believe, regardless of where you come from, if you take the time to figure out what it looks like to do that. And so that's why I think it is such a travesty that we in the healthcare system writ large have done such a poor job of engendering and retaining trust of these populations. Because my experience is that, we train doctors to believe they have the answers, and that's actually not true. The patient, I tell my patients this, you are the expert in your care. You're the expert in your life. You know what it feels like to be you every day. I know all this other stuff about other people that I've read in data and literature, and I went to medical school, and that is all true. But you are the expert in what it feels like to be you every day. So how do we combine our expertise in a way that is mutually respectful, but that doesn't diminish one below the other? And what does it look like then to create systems and processes of communication, of interaction that engender trust? Well, it means A, taking time to get to know a person. B, when they tell you something, listening and acting like you care about it and acting on it if you can. And C, doing what you say you're going to do, following up. And just doing that over and over and over again. And so we've spent a lot of time building sort of our processes and our systems to be trustworthy. And for many of the folks that we care for, they will tell you how different that is from their prior experiences of healthcare. They're used to being made to wait to see a doctor with no acknowledgement that we've taken their most precious resources of their time and squandered it, and with no explanation. Where they're used to saying things like, I feel lonely, or I'm scared, or I'm hungry, and having someone brush past that to talk about their hemoglobin A1C or their diabetes or their kidney function, because we actually have no answers for that. And so we just won't listen. Folks are used to hearing people refer to them by their disease conditions or by their clinical behaviors, as opposed to by their name, like a human. The diabetic in room 3 is a person with a family who has goals and wishes. And if we took a moment to do that, I think we would find it's a lot easier to engender trust and to retain trust in the healthcare system. And certainly that's what we found. And we've researched this. We've built models to measure trust and satisfaction amongst our population that are specifically validated for the population whom we serve. And we hold ourselves accountable to doing that every day in the work that we do.
Any anecdotes, either from your own clinical practice or Cityblocks, where you took a population or a person who was not trusting and were able to turn that around?
Oh, I've got so many. A small example. So I used to do a lot of kind of home visits and community visits for my patients, small cohort of people, very, very high needs. And I would say to them, I'd say, look, if you ever need me, these are often people who are approaching end of life or caring for people approaching end of life, really kind of lots of things going on in their lives. And I'd say, if you ever need me, here's my cell phone number. It's not the number for, some call center somewhere. It's my actual number. Call me and I'll do my best to respond and to take care of you and we'll figure out what you need. And it was a Saturday and my phone rings and I pick up the phone and it's one of my patients and I said, hello. And she said, hello. She said, Dr. Toyin. I said, yes. And I said, are you okay? What do you need? And she said, oh, I was just checking if it was you. I was just testing you. I said, I'm here. It's me. I said, what? But that always made me laugh. And we chuckled for a minute and we hung up. And but the do what you say you're going to do part really matters. And it was surprising to her that I actually answered the phone, even though I told her I would.
Well, I hope that all physicians are listening to this and they will start to give out their cell phone numbers, because my doctor...
Takeaway. Don't let me get in trouble with my colleague peers.
No, but I mean, look, we're all interacting through computers. And, you referred earlier to often in an office visit, you feel like they're not looking at you, they're just typing into the system. And I do think that kind of removing the individual, we talk bedside manner, but we practice computer management through healthcare. So I love that anecdote. It's great. So Toyin, you guys are a tremendously successful company. When I first heard about Cityblock Health, I assumed you're a nonprofit, but I think you were recently valued at $6 billion. And so it's not only been a home run in terms of offering care, but you're worth a lot of money. You have investors, you have their needs to meet. Talk about alignment of incentives between investors and a do-gooder company that is actually trying to make money.
Yeah, I mean, it was really important to us in founding the company that we created a sustainable business model around this work. And so the for-profit part is by design. We wanted to be accountable to creating value for the long term and to creating a business model that would continue to allow us to invest in growth and scale. And we wanted investors who shared an economic motivation to do this, who were willing to put real capital behind our ideas because they believed there was a market that was underserved where we could actually deliver value. And so that alignment at the outset is really important, right? The second thing that was really important was that our business model, as I described, is aligned with doing good, as you say, being a do-gooder, getting the right outcomes. We make money as a business when we engage our members in respectful, trusting relationships such that we earn the right to help them make different choices about healthcare that they utilize, such that they result in better outcomes for them and for their payer. That's the alignment across the board. And so our economic success is directly tied to the model that we put in the world, having the impact on the patients whom we serve that we intend to have. We cannot make money and succeed if we are not engaging, building trust with, and providing excellent care to the people whom we serve. And at the outset, I think being able to sort of almost see the internal logic of all of those pieces, and the alignment of all of those pieces, at the outset allows us to head off potential points of conflict, right? This is not the kind of business where we are grappling every day with, should we turn the screw over here and then shortchange that's not how it works. Like, actually, we focus on, are we providing care to people, because we know that care is going to result in better outcomes. And that was really important. And I think for the investors whom we brought into the business, they are first and foremost accountable to their shareholders. And they're accountable to the folks whose capital they've been asked to steward, which means they had to vet us for, is this a team that can execute on an idea that we believe in a market that we believe has legs and is big enough to support the return profile that we need to see. That was their calculus. That's how they do their job. I think it helps, certainly, that this was an under-penetrated market where we had the opportunity to really be a first mover. And the reason it's an under-penetrated market is because it's hard, and the people we serve are complex. And I think it helps a lot that we were able, when we were fundraising, to select who we wanted to work with. And, we selected people who share our values and share a desire to have real impact in the world, and to do what's right. And that has allowed us to really build a great cap table, a great group of collaborators and investors, who ultimately are holding us accountable to doing what we said we're going to do, which is to deliver economic value by providing a really excellent quality of care and experience of care to the people whom we serve.
Excellent. Look, just to end up, I can't not ask a couple of current event related questions. The cuts in Medicaid that happened in this, quote, big, beautiful bill.
Yeah, I'll talk about the big, beautiful bill. The bill has come out. The rules now need to get promulgated, which is where I think a lot of the nuance is in the details of the rules. I think we all understand the sort of the motivation behind this, right? Like, there's a desire to find cost savings, and to eliminate any sense that there are folks who are benefiting from these benefits for whom it was not designed, who are not entitled to them. I think we also know that that unless well executed, a lot of the changes to Medicaid are likely to result in more friction in accessing care, and probably won't achieve the desired outcomes over the long term. But I think there's an opportunity using technology to really align and create visibility for people on Medicaid, for the state, for the federal government, about who's entitled to what, who's working, who's not working, where those benefits come into play, and to streamline what has been administratively a really, really difficult and messy process in many states for many people. And so I'm cautiously optimistic that as we get into the details, we'll be able to really see this administration take a thoughtful approach rooted in the sort of the time that we're in now, where we have access to these incredibly powerful technological and data tools, to really allow us to do this well, such that we're mitigating any potential downside and also achieving the desired outcomes. But there's a lot here, and there's a lot we still don't know. And I think a lot of opportunity to really hopefully shape, with the right voices in the room and the right stakeholders incorporated, to shape an outcome that will turn out, to have modernized our program, which is, I think, what the goal is that we all share. So I'd really love to see that. I think there's a lot of rhetoric right now, but when I spend time with folks across the political spectrum, people often want the same things. People are saying that they feel that we are not focused on the right things as a country. They feel that our systems and processes and rules are not designed to help them, typically sort of the average person, achieve a healthy and productive life. That is what people are grappling with. And the explanatory models that have been promulgated for why that is true run the gamut from DEI all the way through to, immigrants, all the way through to, complex, difficult to follow, wonky policy arguments. And what we have not done as a nation is align on a real understanding of how we got here. The most prosperous, I believe the most incredible nation on the planet that is unable today to guarantee equal access, fair access, high potential opportunities for everyone on the basis of their effort and their deservedness as a human being. Like, we just don't do that, right? Like, and we're actually seeing the sort of the metrics for upward mobility for individuals, for family members, they're diminishing over the decades, as opposed to improving. And so there's something here that like really gets in people's craw and like makes them angry and hankering for answers. And we need to figure out what it is. Like, what do we need to do to solve for that? What is the right culprit and what's the right point of leverage? And I don't know that any of those explanatory models, certainly they don't resonate for me. But I think it doesn't almost matter what I think. It matters what we as a collective are going to rally around, and therefore what policy interventions we're all going to support and seek from our leaders.
So well said. Let's just wrap up with one final question. You've been so successful. What would your advice? You said earlier in the podcast that you've figured out that the frictions in the entrepreneurial journey really have to do with sales and negotiation. And so you wish you'd known that earlier, but put yourself in the shoes of a 25-year-old entrepreneur starting his or her company. What would be the lessons that you would impart to them around learning negotiation other than just on-the-job training?
Take your class. I mean, I think to me, negotiation is about listening, because as an operator, one of the things I love about operating is you get feedback, and you can try something, and if it doesn't land or you doesn't get the desired outcome, you try again. Sales and negotiation, if you are listening for both spoken and written feedback and body language, you know if it's working or not. You know if people are leaning forward to listen to what you're saying. You know if they follow up. You know if they can repeat back to you what you said. You know if you hit them with the exact unlock that's going to really change the way they think about a topic. Like, persuasion is such a trainable skill if you are listening. And so I think the big piece of advice I would give is listen and learn to pay attention to how people react to what you are communicating. And then start to experiment, because everybody's sales approach, everyone's style of communication is different. Figure out what you're good at. Figure out how you are your most persuasive. Listen for feedback and seek to learn about what matters to the person whom you're seeking to persuade. And then you get better at it. That's it.
Love it. That's a great response. Toyin, thank you so much. We're out of time. I could go on for hours, and we might have to do a part 2 to solve all the other problems that you're not focused on in the healthcare system. But thanks so much for being a guest.
Thank you.
Thanks for listening to All Things Negotiation. Please subscribe to the show on Apple, Spotify, or YouTube. If you enjoyed the show, tell a friend, and be sure to engage with us on social media. Your likes, comments, and reposts make a big difference and help others find the show. The show was produced by Ezra Trupiano, original music by Peter Breinhold, and designed by Aubrey Benson. Thanks for listening.